Hi everybody, welcome to Dr. Manny's YouTube Learnshops. What we'll be looking at today are common pediatric electrocardiographs, and this is part 1. And the objective of this Learnshop, or these 4 parts to the Learnshop, are for you pediatric nurses who monitor cardiac rhythms, and they will provide fundamentals, essentials about pediatric arrhythmias and dysrhythmias, and be aware that they're often associated with congenital heart disease. The learning objectives for this session, part 1, are to see what you know. Now, it'll be interesting to see, okay, for you. We'll briefly review some cardiac anatomy and physiology, some basic or fundamentals related to electrophysiology, and then electrical axis. So let's start. This is your knowledge review. Which of the following is the normal pacemaker of the heart? SA node, AV node, His node, or Purkinje fibers? Correct answer is the SA node, the sinoatrial node. Which of the following are components of the conduction system of the heart? SA node, AV node, and His node, Purkinje fibers, or all of the above? All of the above is the correct answer. Which of the following statements represents the P wave? Is it ventricular depolarization, atrial repolarization, ventricular repolarization, or atrial depolarization? The correct answer is atrial depolarization. Which of the following statements relates to the sympathetic nervous system? Does it increase heart rate? Does it increase conduction speed? Does it increase contractility of the myocardium? Or does it do everything? All of the above. The correct answer is all of the above. Okay. Which of the following statements is correct about normal heart rates? Does a child have a heart rate of 60 to 100 beats per minute? Does a newborn have a heart rate of 50 to 80 beats per minute? Does an infant have a heart rate of 35 to 85 per minute? Or are they all correct? Well, they're not all correct. The correct answer is that a child has got a heart rate between 60 and 100 beats per minute at rest. Which of the following relates to the parasympathetic nervous system? Does it slow conduction of the SA node, AV node, heart rate? Is it all of the above? Which is correct? All of the above is correct. Which of the following are considered the standard ECG leads? A, B, C, or D? The correct answer is all are considered to be components of a standard ECG lead system. Which of the following relates to sinus tachycardia? Is it due to parasympathetic nervous system stimulation? Does it have a heart rate of 40 beats per minute? Does it decrease myocardial oxygen demands? Or is it none of the above? The answer is none of the above. Which of the following connect to atrial fibrillation? Is it A, B, C, or D? The correct answer is all of the above. Which of the following then relates to premature ventricular ectopics, PVCs, premature ventricular contractions, complexes? The correct answer is all of the above. Now, can you name the following ECG anomalies? So look at the rhythm strip. What's the anomaly? Correct. Premature ventricular complexes, or PVCs. And these are called couplet because they're together. Can you name the following ECG anomaly in this very fast ECG rhythm? This is a supraventricular tachycardia, SVT. You could call it an atrial tachycardia. What about this ECG anomaly? Ventricular fibrillation and its course. What about this one? This is asystole. What about this ECG anomaly? Very irregular. This is atrial fibrillation. And this is actually atrial fibrillation with a controlled ventricular response. Some people say slow AF. There's really no slow AF, but this is atrial fibrillation. Now let's briefly review some of the anatomy and physiology related to this topic. And this is just an overview. Approximately 18 to 21 days post-conception, the heart is already beginning to beat and function and connect with the cardiovascular system. The heart's beating at approximately 70 to 80 beats per minute. Red blood cells are being created, hemopoiesis, and the circulation has begun, which requires movement around the developing embryo. The heart's already fusing into a primitive heart tube, and it's interesting to note that a human heart beats approximately 3.5 billion times in a normal lifetime. Approximately 1 month, 35 days post-conception. Externally, the heart's looking a little bit like the heart with its great vessels, and the SA node and the conduction system are already starting to become developed more effectively. Day 52, post-conception. Internally, the structure of the heart is more as we know it, and the conduction system, SA node, AV node, his Purkinje system is almost developed. At 40 weeks, the heart rate is approximately 130 beats per minute at rest with no fetal distress. At term and at birth, these are approximates in relation to normal cardiac details. The heart is located in the middle of the chest, the thorax, in the mediastinum between the lungs. The base of the heart is level with the second intercostal space, and this is where the great vessels, aorta, pulmonary artery, exits. The apex is located at the fifth intercostal space in the midclavicular line, immediately above the diaphragm. In relation to the weight, there's right ventricular dominance, because in the fetal circulation, the right ventricle has had to do most of the work. The left ventricle in the fetal circulation hasn't had to do too much. So the weight ratio is approximately left ventricle smaller than the right ventricle. And the size, you have right ventricular dominance. So the right ventricle is approximately 4 times larger than the left ventricle, because it's had to work pretty hard during the development of the embryo to the fetus to get it to the stage of term. The electrical axis, therefore, because of right ventricular dominance, is a right axis, which is typically 90 to about 180 degrees. However, following birth, the heart rate in the left ventricle has to work a bit harder. So there are increased demands on it, which will change its structure over the next 3 to 4 years. When a child reaches about 3 to 4 years of age, fundamentally, it's like an adult. And because the left ventricle has had to work fairly hard over that period of time, pumping blood into the systemic circulation, it's become more dominant. The right ventricle has become less dominant because it's only had to pump blood into a fairly low resistant circulation, the pulmonary circulation, and as a consequence of that, the left ventricle has become larger. So the weight ratio, the left ventricle is about 2.5 times heavier than the right ventricle, and its size has increased from 1 to 5 times larger than the right ventricle. When we look at the heart, we look at the cardiac cycles. And essentially, there are 2 cardiac cycles. The one that we're looking at today is really the electrical cardiac cycle. And it's the electrical cardiac cycle that results in depolarization and repolarization of the atrial and ventricular myocardium. And this creates now the ability for the heart to pump blood. But this is electrical, and this is the one that we're measuring here today in the electrocardiograph. However, without the electrical cardiac cycle, we cannot have this one. This is the mechanical cardiac cycle. This is pumping. And this is the cardiac cycle that actually pumps out the blood, systole, and allows the heart to fill diastole. Fill, empty, fill, empty, fill, empty, systole and diastole. And they work together. The electrical cardiac cycle allows the mechanical cardiac cycle to function. When we look at the cardiac conduction system, it consists of the following components. You've got the SA node, the sinoatrial node, which is also referred to the node of Keith and Flack. And this was discovered in 1907 or 1907. And it's the intrinsic pacemaker of the heart that's located around the level of the superior vena cava. Then you've got the intra-atrial pathways, and they were discovered in the early 1900s by 3 physiologists, Bachmann, Wenckebach and Thorell, and these connect to the AV node, the atrioventricular node, which was discovered in 1906 by a Japanese physiologist, Tsunowa Tawara, and the AV node is referred to as the junctional node and sometimes the Tawara node. Then the AV node connects to the His node, which is just a continuation of the atrioventricular node, and this was discovered in the late 1800s by Wilhelm His. This connects to the right and left bundle branches, which connect to the Purkinje fibres. And the Purkinje fibres were discovered in the mid-1800s by Jan Purkinje. And these anatomists and physiologists and physicians and scientists were the ones that named the cardiac conduction system. If we look at it in a little bit more detail, we look at the SA node. The sinoatrial node is considered to be the intrinsic pacemaker of the heart because it can depolarize faster than any of the other pacemaker or conduction tissue under normal circumstances. And it's sited in the subepicardium at the junction of the superior vena cava and the right atrium, and it depolarizes at rest in the neonate between 100 and 150 beats per minute, in the infant or the younger child 80 to 120 beats per minute, and in the older child and adult, let's say adolescent, between 60 and 100 beats per minute, because we're looking at pediatrics here today, not adults. Then you've got the intra-atrial pathways, which connect the SA node to the AV node, and the pathways are Bachmann, Wenckebach and Thorell. Wenckebach is the middle, Thorell is the inferior portion that connects on the right side of the heart, and Bachmann is the superior portion that connects the SA node to the left atrium. And when the SA node depolarizes into the intra-atrial pathways, the speed is about 1,000 millimeters per second. Very, very, very fast, to make sure that the atria are stimulated at exactly the same time so they contract synchronously and empty blood into the right and left ventricles. Then you've got the AV node, the atrioventricular node, the junctional node, the node of Tawara, and it's considered to be the secondary backup pacemaker. And it's sited in the subendocardial tissue at the junction of the atrial and the ventricular. This is the atrial ventricular junction. And it depolarizes at a generic speed between 40 and 60 beats per minute in the neonate, infant and child, adult, or child and adolescent at approximately 40 to 60 beats per minute. And when the current from the SA node gets to the AV node from the intra-atrial pathways, it slows right down to about 200 millimeters per second from 1,000 millimeters per second to give time to the atria to contract and empty their contents, blood, into the right and left ventricle. Then you've got the His-Purkinje system. And the His-Purkinje system, I've labelled the third or tertiary backup pacemaker. It isn't really. However, sometimes it will work if the SA node and the AV node have failed for whatever the reason, but it's not guaranteed. And the His-Purkinje system consists of the following: the distal AV node, the His bundle, the ventricular septum has got the bundle branches right and left, and the myocardium, ventricular, has got the Purkinje fibers. And it depolarizes at a generic rate between 20 and 40 beats per minute in all three populations: neonate, infant, child, younger child, child, adolescent, or adult. However, when it leaves and enters the His-Purkinje system, the depolarization speed has gone from 200 millimeters per second to 5,000 millimeters per second, because it's got to depolarize the ventricular tissue very, 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 very quickly, because there's a lot of tissue to depolarize, in order to get synchrony, meaning that the ventricles, right and left ventricle, contract at exactly the same time and push blood into the pulmonary and the systemic circulation. This is always interesting, and I've only given you a little bit here. This is about the history of electrocardiography, which I think is important for you to be aware of. And this is a historical overview. In 1901, or 1901, or 1901, Willem Frans Eindhoven invented the ECG, which was really a galvanometer. A galvanometer is a device that measures small electrical currents. And as you can see in the picture, that's Eindhoven's first patient. And he didn't have fancy electrodes, he had 3 buckets of sodium chloride, salt water. And salt is a very good conductor. And he created the first 3 ECG electrodes, which he labelled RLF, right, left and foot. Right arm, left arm and foot. And he also labelled them, not in 1901, but later, to PQRST. And they don't actually mean anything, they just represent things. He actually wanted to call it ABCD, and then ABCDE, but he wasn't allowed to, because the scientific community had already used those alphabetical letters for other areas in science. And they'd actually used A, B, C, D, E, F, G, H, I, J, K, L, M, N, O, P, or L, M, L, M, N, O, and he was left with P, Q, R, S, T, U, V, W, X, Y, Z. So he chose PQRST to label his waveforms. So there wasn't any specific reason why he chose those, as I said. That was just what was allowed him to have. In 1934, Frank Wilson created an extension of the ECG that Eindhoven created. And he labelled the standard leads VR, VL, VF, which just means vector. And he also created lead 1, 2 and 3, the standard leads. Later on, he created the Precordial Leads, which basically means pre-coronary on the chest. So they're chest leads or precordial leads, V1, 2, 3, 4, 5, vector 1, vector 2, vector 3, vector 4, vector 5, vector 6, or you can call them C1, C2, C3, C4, C5, C6 chest leads. In 1942, during the Second World War, Emanuel Goldberger increased the voltage of the galvanometer, the ECG machine, by 50%, so that people reviewing and recording had a larger ECG. In the standard leads, this added an extra alphabetical, which was A. The A stands for augmented, made bigger. So AVR, AVL, AVF were created. And lead 1, lead 2, lead 3 also became bigger as well. All these guys were partly engineer, inventor, anatomists and physiologists, and related to looking at the heart in some aspect. These are some electrophysiological concepts that I think we need to continue with. And they're concepts that relate to depolarization, and what you're seeing in front of you is the action potential, simply, and the big ECG. Now, in order to get a big ECG, you need millions of these little action potentials. And they are all measured and they are combined on the big ECG. Measurement of small currents, galvanometer. So depolarization is represented by a positive deflection. And this is when sodium goes into the cell and depolarizes the cell. It creates millions of little deflections, action potentials, which are combined and recorded on a big ECG. And the big ECG that you're looking at currently here is showing you ventricular depolarization, the QRS complex. Ventricular depolarization has got another component to it before, and this is called atrial depolarization. And as Eindhoven did, he represented atrial depolarization by a P wave and ventricular depolarization by a QRS complex. D just means to change in Latin. So you're changing polarity. You're creating a positive deflection. The P wave represents atrial depolarization or stimulation, if you like. And the QRS complex is representing ventricular depolarization or electrical stimulation. Then it's got to go back. In order to depolarize, you have to repolarize. So depolarize, you can think of as discharging the battery, and repolarizing, recharging the battery. So if you're recharging the electrical battery of the heart, then sodium and potassium have to move out of the cell, and this creates a negative deflection to repolarize, recharge the battery. And this can be measured as well by measuring all the different action potentials, and that creates on the big ECG the ST segment and the T wave. And this represents ventricular repolarization, recharging of the battery. Because if you want to discharge the battery again, you better repolarize pretty quickly. Because remember, the heart is beating anything depending on the age group from 60 to 150 beats per minute. Now, what I haven't shown you here is atrial repolarization. And you can look it up, or if you want, you can let me know, and I can give a topic on that. But it's in the literature, and you can look at it on Google. And atrial repolarization is represented by what is called the TA wave, the atrial T. And you don't see it, but it follows the P wave, which is the positive deflection, as a negative. But it's typically hidden in that flat line that you see, which is called the PR segment, the TA wave. Ventricular repolarization, or recharging of the ventricular battery, is represented by the ST segment, early repolarization, and the T wave, a little bit later repolarization, if you want to think of it as that. Now, if we take it a step further, we're going to look at electrical axis. And depending on the population, meaning that you're newborn, young infant child, older child, adolescent or adult, the electrical axis changes. So let's comprehend, first of all, that if an electrical current goes towards an electrode, it will create a positive deflection on the ECG. If the current is going away from the electrode, it creates a negative deflection on the ECG. If it's doing a little bit of both, perpendicular to the electrode, so the current is going towards and away from the electrode, which is typically going to be perpendicular to the electrode or 90 degrees to the electrode, it creates a biphasic deflection on the ECG, which means both positive and negative. So taking Eindhoven's triangle, which is the right arm, left arm, and foot, we create this. But remember, he didn't have lead 1, lead 2, or lead 3. This was created later by other inventors. But they took Eindhoven's triangle from 1901, essentially. And this is what it is, even though already this triangle is more advanced than what Eindhoven had. We've got the right arm electrode, left arm electrode, and left leg electrode, or the foot. The heart is essentially considered to be at the centre, which is 0. This is where all the electrical current is coming from. So, if we measure the electrical activity going away from the right arm, this creates a negative deflection. So look at AVR. It is all negative. It's upside down. It's going away, because the right arm electrode sees the current going away primarily in someone who's left ventricular dominant. Because remember, this ECG was created for adults, not for pediatrics. It's had to be modified in some ways. Then you've got, if current is going towards the left arm, remember most of it is going down towards the left side, but a little bit goes up. So a little bit goes up, it creates a positive deflection, but most of it's going away. So it creates a negative deflection. AVL is typically a biphasic electrode, which means it's got a positive and a negative phase to it. The current, however, is going down towards this area, the foot, because that's where the left ventricle is really pointed to, left ventricular dominance. But again, it depends, as you'll see when we review a little bit later on in this session, where the electrical axis is going. But in the older person, or the adult, or what Eindhoven invented it for, they're left ventricular dominant. So therefore it will be going towards the left leg electrode, which means it will be primarily positive. These are your augmented limb leads, AVR, AVL, AVF. And they were combined by Frank Wilson in 1934 to create lead 1, which is a bipolar lead. AVR, AVL and AVF are unipolar leads, one direction only. But AVR and AVL combined create lead 1, a bipolar lead. And it's a combination. So therefore it will create a biphasic lead. Then you've got lead 2, which is a combination of AVL and AVF. Then you have lead 3, which is a combination of the right arm electrode, AVR, and the left arm and left leg electrode, AVF. These are our 6 standard limb leads that come off your limbs, your arms and your left leg, which I haven't included here because it's for monitoring. You do have a left arm electrode, or a left body electrode, or a left leg electrode here in a lot of standard monitoring leads here, but that doesn't really do anything. It just takes away electrical and muscle interference. We only typically have 3 leads: AVR, AVL and AVF. They create lead 1, 2 and 3. Let's take Eindhoven's triangle a step further for comprehension. This is referred to as the hex-axial reference system, which basically means hex, Greek, 6, axial, direction, reference point. These are 6 electrical views of the heart. And the heart, essentially in Eindhoven's theory, is at the center of the triangle, which means it's got 0 potential. Everything is coming from there, so the heart is considered to be 0. When we look at the hexaxial system, we look at it from the frontal plane, which means from the top to the bottom, which means superior to inferior, and from right to left. That's the frontal plane. Heart is at the center, which means 0 potential. And everything transects it. So therefore, lead 1, lead 2, lead 3, AVR, AVL and AVF all transect the heart to give you this hexaxial system, or this frontal plane system to monitor and record and give you information about where the electrical action is originating from and where it's going. If we look at AVR, AVR's got a positive pole and a negative pole. If everything is working correctly, current goes away from AVR, from the negative to the positive, which means AVR will always look negative. If it doesn't, something's wrong. You've either got the leads on the wrong way, or the heart is in the wrong position. And the most common condition is called Dextrocardia, where the heart is now located in the opposite direction. Left ventricle is on the right side and right ventricle is on the left side, which can happen in congenital cardiac anomalies. Then you've got AVL. AVL is biphasic, as we said previously. Because remember, current is going up, but most of it's going down towards the left ventricle. So AVL will see current going away from it primarily towards the left ventricle, which is down towards the inferior portion. Then you've got AVF. And AVF is in the direction primarily of the left ventricle. So it should be positive. So out of the 3 augmented leads, AVF will be the most positive, AVR will be the most negative, and AVL will be somewhere in between. If you have left ventricular dominance, which is typically what you see in an adult, because Eindhoven, as I said, didn't make the ECG for pediatrics. He did it for adults. He wanted to look at the adult heart. When we combine AVL and AVF, we get lead 1. And lead 1 is a combination of AVL and AVF. Lead 2 is a combination of AVL and AVF. Lead 3 is a combination of AVR and AVF. These are your 6 limb leads in the frontal axial plane. 3 are unipolar, AVR, AVL and AVF. 3 are bipolar, lead 1, lead 2, lead 3. AVR, AVL and AVF create lead 1, lead 2 and lead 3. If we look at it in a little bit more detail, you've got the adolescent, let's say, not the adult, or the child that's older than 3 years of age, 3 to 4. And typically they're left ventricular dominant, which means their left ventricle dominates the ECG complex being recorded. And typically it will be from 0 to 90 degrees, although other academics say from -30, sometimes up to 120 degrees. If we look at the ECG then lead 2 is in the middle. So therefore it will probably be the best lead for monitoring because it's the most positive, you can see it more easily. And as I said, the 3-year-old child is similar, not exactly, but similar to an adult in relation to the electrical axis. So it's typically going to be from 0 to about 90 degrees. And lead 2 is somewhere in between that. When we look at the infant or the child that are less than 3 years of age, but not newborn, their electrical axis is typically going to be from 0 to 120 degrees. On the graph here now, I've left it on the hexaxial system, I've left it at 0 to 90, but it should be 0 to 120 degrees because it's in the transitional stage. And basically what that means is the right and left ventricle are transitional because they're halfway in between where they're wanting to go. But everybody's different, so it's difficult to access. So we look at the electrical axis as being from 0 to about 120 degrees because the ventricle's about the same size. Remember, the left ventricle was a quarter the muscle mass of the right ventricle, but they're in a transitional stage where the right ventricle is getting smaller, less muscular, and the left ventricle is getting more muscular as it has to work harder over the next 3 to 4 years. So in the child or the infant, the electrical axis is approximately 0 to 120 degrees in the transitional stage. If we look at the ECG then, because it's transitional, AVF will probably be the most positive lead and probably the best lead for monitoring the ECG. It's transitional or intermediate, halfway in between. In a newborn, they're right ventricular dominant. Remember, because in the fetal circulation, the right ventricle did most of the work. It was 4 times larger than the left ventricle. So therefore, at birth, or certainly up until the first couple of months, even first year, they are still going to be right ventricular dominant and on the ECG complex. So therefore, this will be from approximately 90 degrees to about 180 degrees, but maybe even more. Depends. In the newborn, they are right ventricular dominant, and their electrical axis can be anything from plus 90 degrees to plus 120, minus 120 degrees. But I've left it there at a 90 degree angle. So on the ECG, Lead 3 will probably be the most important lead for monitoring the electrical axis. It'll give you the best picture. They have a right axis, which is considered normal in the hexaxial system. So let's review some heart rates. And I prefer the word typical to normal. Typical heart rates then for a child, an adolescent, even an adult, more than 3 years of age, at rest, with no problems, will be between 60 and 100 beats per minute. Anything less than that will be a bradycardia. Anything faster than that, a tachycardia. Anything faster than 160 could be, not will be, could be a supraventricular tachycardia. But this goes on the history and the physical assessment. And always remember that just because you've got a slow heart rate doesn't mean you're clinically compromised. You could be parasympathetic dominant. You could be sleeping. You could be sympathetic dominant and have a faster heart rate. Upper limits of normal, lower limits of normal. Depends on you. We're not all the same. When we look at the infant or child less than 3 years of age but not newborn, resting heart rate will typically be between 80 and 120 beats per minute. Anything less than 80, a bradycardia. Anything faster than 120, a tachycardia. Anything faster than 180, possibly a supraventricular tachycardia. When it comes to the newborn, at rest, no distress, resting 100 to 150 beats per minute. Anything less than 100 is a bradycardia. And it doesn't mean they'll be clinically compromised, but they could be. Anything faster than 150 is a tachycardia. Again, it doesn't mean they're clinically compromised. Look at the clinical circumstances. Anything faster than 200 is probably going to be a supraventricular tachycardia. So, that's the end of part 1. If you found this of any interest or value, move on to part 2. Thanks and see you then.